So the thing which keeps us going on is the sleep. So what is sleep? In simple words, taking rest. Okay, so it is actually an act with which we convey an information, with which we convey the message to the world and to all the voluntary activities of our body that I am tired now, not ready for any activity right now, but I will see you soon. So with this, I would start my topic, effects on sleep and sexual life. And if I am able to make any of you sleep during my presentation, I would be more than happy, and I would think I have delivered a great talk. Okay. So sleep, state of reduced mental and physical activity in which consciousness is altered and certain sensory activities are inhibited. Adults nearly spend 30% of their whole lifetime in sleep. Sexual health, as we all know, a state of physical, emotional, mental, social well-being in relation to sexuality and not merely absence of disease, dysfunction or infirmity. So normal sleep physiology, there are two phases, mainly the non-rapid eye movement sleep and the rapid eye movement sleep, which contains a total duration of 70 to 100 minutes, one cycle, sometimes extended to 120 minutes. So NREM sleep has four phases mainly. The first two phases are the lighter phase, where there are sleep and waking up cycles. The next two phases, 3 and 4, are the deeper phase, known as slow wave sleep. And the REM stage, finally, in this stage there are skeletal muscles are immobile, only the movement of eye is seen and the breathing muscles are active. And 4 to 6 cycles of REM sleep are there with an interval of approximately 90 minutes. So what is the relationship between sleep and testosterone? So there are many hormones and neurotransmitters related to sleep, but we are mainly concerned about testosterone and estrogen. So we all know that there is a regulation of hypothalamo-pituitary gonadal axis. Plasma testosterone is higher when we wake up and decreases as the day passes by. Plasma testosterone levels begin to increase with onset of sleep, making a peak at the first REM sleep, and then the level is almost maintained, and followed by a 90-minute time where there is a burst which shows its relation to the NH secretion. Now, the testosterone secretion during the sleep is not dependent on day or nighttime sleep. Total segmentation definitely causes a decrease in the level of testosterone, and testosterone deficiency may have deleterious effects on the sleep and can be overcome by testosterone replacement therapy. But if they are used in an abusive potential, if the doses are too high of exogenous testosterone and anabolic and androgenic steroid abuse is there, so abnormalities of sleep duration and architecture is seen. There are certain sleep disorders which also affect testosterone release, that is the sleep restriction. So sleep restriction lowers the testosterone, and the first 3-4 hours of sleep is critical in determining the further release of testosterone. Obstructive sleep apnea has no direct or indirect effect, has no direct effect, and vice versa. And its treatment with CPAP does not increase or decrease the level of testosterone and vice versa. And circadian rhythm disruption definitely decreases testosterone levels. Now, estrogen and sleep, fluctuating levels of hormone causes insomnia, hot flushes, and change in mood in females during the perimenopausal stages. Sexual sequelae includes reduction in the vaginal lubrication and elasticity, thus experiencing dyspareunia, dislike of sensual touching, and overall loss of libido and lack of well-being. And sleep disturbances is probably due to decline in estradiol levels. Estrogen therapy has a role. It actually reduces the hot flush frequency, nighttime awakening, and increases rapid eye movement, which actually positively affects the body image, mood, and definitely the sexual desire. Sleep disorders, as mentioned by American Academy of Sleep Medicine, has 7 disorders, mainly insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm, sleep disorders, parasomnias, sleep-related movement disorders, and other sleep disorders. So first we start with insomnia. So what is insomnia? Difficulty in falling or staying asleep, even when a person is given chance to do so. Other symptoms are fatigue, low energy, difficulty in concentrating, and there is a learning and occupational difficulty also. There are two types: primary insomnia, which is of psychophysiological origin, where there is difficulty in falling and maintaining sleep, and there is secondary insomnia, which is related to mental disorders, medical conditions, and other sleep disorders. So, male and female have a different circadian rhythm. The males have a 6-minute longer circadian rhythm than the females. So, females tend to fall asleep or be tired in the evening compared to the males. Okay, so insomnia directly affects the daytime activities of the couple, making relationship and sexual activity difficult. So, what usually happens in insomnia is there is an increased sympathetic activity, which gets relieved with successful sexual intercourse followed by an orgasm. This results in a parasympathetic discharge connected to psychological and physical relaxation, and that promotes sleep. But what we have seen usually is there is an experience of full cycle. If there is an experience of full cycle, there is an orgasm and there is a resolution phase. That induces a state of relaxation, which is especially in male because they are comparatively easier to achieve orgasm, and there is a refractive phase also. Whereas persistent excitement of sympathetic nervous system and the sense of discomfort if the sexual contact is not completed with orgasm. So, which leads to a persistent arousal state, and this has been seen in females usually, because we all know that there is a difficulty in attaining orgasm. So how do we treat? We have some drugs like orexin receptor antagonists, hypnotics, short-acting, classical benzodiazepines, sedative, antidepressant, and melatonergic drugs. And in case of comorbid anxiety and depression, we can use some antidepressant drugs before using any kind of sedatives or hypnotics. Obstructive sleep apnea, disorder characterized by repetitive cessations of breathing due to collapse of the upper airway during sleep. According to a meta-analysis, there is 1.82 relative risk of ED and 2 relative risk of female sexual dysfunction overall in case of obstructive sleep apnea. And it is a main factor of risk factor for arterial hypertension, diabetes, endothelial dysfunction, and decrease in testosterone levels, which actually are all known causes for sexual dysfunction. Now, there are certain hypotheses related to obstructive sleep apnea and erectile dysfunction. One is that during REM sleep time, physiological erections appear to maintain erectile function through cavernosal tissue oxygenation. But in oxidative stress, which are due to ODA, obstructive sleep apnea, there is endothelial cells lose their ability to secrete the nitric oxide, leading to inhibition of smooth muscle relaxation and subsequently inadequate endothelial vasodilatation of the corpora cavernosa. Another hypothesis is the hormonal one, where there is impairment of hypothalamo-pituitary gonadal regulatory system, causing decrease in the testosterone release. This leads to hypoxemia, and this hypoxia can cause neural changes also, and there is an impairment of the pudendal nerve transmission and eventually pulvocavernosus reflex, which can cause ED in case of OSA. Treatment first is the pneumatic straightening of the upper airway by CPAP. Other modalities are surgery and mandibular advancement devices, and the best thing is if we can combine CPAP and PD5 inhibitors. And testosterone replacement is usually contraindicated in patients of OSA if it is not treated properly. Circadian rhythm sleep-wake disorders are disorders caused by alterations in circadian rhythm, its entrainment mechanisms, or misalignment of endogenous circadian rhythm and external environment. So mainly there are two types, the intrinsic one and the extrinsic one. Intrinsic one could be delayed sleep, advanced, irregular, and non-entrainment to 24-hour light dark cycles. And extrinsic mechanism they are caused by differences in the time zone, the night shift workers, and the people suffering from jet lag. So usually what happens is there is a negative effect in quality of life. So there is a negatively effect of quality of life, quality of sex life, including preferred sexual timing intercourse. Sharing a bedroom with a partner who has a different circadian rhythm than yours actually kind of affects your sleep and the overall sexual satisfaction and relationship. It is especially problematic when the partners, seen that mostly males are there, stays active for a long time in the night and disturbs the partner's sleep. And then when they ask for a sexual intercourse during late hours, the partner is usually very much drowsy and they rejects the sexual invitation. Now the most effective treatment are melatonin administration and light therapy. Psychoeducation should be related to sleep patterns and negotiating sexual contacts. Behavioral interventions include timed sleep, sleeping and waking up at the same time even if you do not have to go for any kind of work. Spend as much time as possible during the daytime in bright light and try to avoid being in bright light during the evening hours and refrain from any kind of physical or mental activity 3 hours before going to bed. Other sleep disorders are central disorders of hypersomnolence, includes condition with inability to stay awake and alert during the major waking up episodes during the daytime. Could be primary conditions and secondary conditions. Primary conditions are due to intrinsic abnormalities of the central nervous system like narcolepsy, idiopathic hypersomnia and clean level syndrome. And the secondary forms could include medical and psychiatric disorders. Narcolepsy means the sleep disorder characterized by excessive daytime sleepiness, cataplexy is there, hypnagogic hallucinations and sleep paralysis. Cataplexy, when is seen during the sexual intercourse, it's known as orgasmolepsy, and there is a loss of muscle tone during the later phases of sexual activity. Okay,
What happens during cataplexy?
So cataplexy, the muscle tone is lost.
So as a result?
So as a result, sleep is there.
While having intercourse?
So during the later phases of intercourse, during near to the orgasm phase and near to the resolution phase.
The dose of?
Yes, sir. Excessive daytime sleepiness and insufficient arousal could be the gating mechanisms, and the symptoms could be related to affective or anxiety disorders with coexisting sexual desire decline that could lead to sexual disinterest, decrease in sexual responsiveness and secondary sexual dysfunction. Now, the treatment could be anti-cataleptic drugs which can be used in orgasmolepsy also, and alternative options are tricyclic antidepressant, SSRIs, SNRIs, norepinephrine reuptake inhibitors and monoamine oxidase inhibitor, type B inhibitors. Now there are some other disorders, for example sleep-related movement disorders characterized by simple movement occurring during sleep or urges to move before falling asleep. So the most frequent are the restless leg syndrome and the periodic limb movement disorder. Waking dysesthesia can be seen in restless leg syndrome and it accompanies, it has two types. One is the restless genital syndrome and the other one is burning mouth syndrome. In restless genital syndrome, there are episodes of excessive and persistent sensations of the genital and clitoral arousal, either mixed with restless leg or overactive symptoms of overactive bladder, and an absence of conscious feeling of sexual desire. And there are no causes, there are no common treatment for this, but we can use some dopaminergic agents like pramipexole, lopinirole, and pregabalin. The other disorders, for example, parasomnia, undesirable events during sleep, for example, dreaming, misinterpretations, misperceptions, dysphoric emotions, abnormal sleep-related movements and behaviors, and dysregulated autonomic nervous system function. The most common sexual sequelae are sexomnia, sleep sex, or somnambulistic sexual behaviors. So we can easily observe that there are profane vocalizations, inappropriate fondling or touching, masturbation, oral sex, and sometimes sexual intercourse. These behaviors are without conscious awareness and frequently without any dream meditation also. The behaviors occur during the rapid eye movement, and the possible mechanism is the sleep and wake states during the NREM sleep. Partners can suffer from physical injuries. Both the actor and the partner have some kind of psychosocial after effects like guilt, shame, embarrassment, low self-esteem. Sexomnia obviously have some relationship issues, and a treatment would be implementing some rules of sleep hygiene, avoiding sleep deprivation and maintaining regular sleep schedule, limiting use of alcohol, and pharmacological treatments can be used, for example, benzodiazepines and hypnotics. We know that there are some sleep disorders which are related to sexual lifestyle changes, for example, stress, low physical activity, irregular bedtime, too short sleep cycles during working days, and trying to actually compensate during the weekends. So there are some sleep cycle, sleep hygiene rules which we can tell our patients: reduce or increase the time spent in bed, mostly 6 hours, 7 hours or 5 hours, depending upon the type of insomnia. Get tired physically in the late afternoon, avoid daytime naps, avoid sleeping pills regularly because they are not curing the disease naturally. Avoid, keep regular lifestyle that means work and everything, and avoid bright and blue light in the evening and during the night. The morning erections, earlier known as the nocturnal penile tumescence, now they are known as sleep-related erections, as we all know. Earlier they were known to be because of the full bladder or because of some unhealthy thoughts or dreams. But after, and in order to stop those things, people use the spermatoria ring, which has a metal outer and inner ring, and there are pointed tooths. So they used to wear them during the night. If there is an erection, they get the pinch of the tooth, and then there is suppression of erection. So there are certain factors, for example, neither presence or absence of sexual dreams, pre-sleep sexual activity, and abstinence of sexual activity causes any change in your NTPR, nocturnal penile tumescence, and low androgen, diabetes, hypertension, smoking, alcoholism. There are some factors which actually affects the sleep-related erections negatively. Now, in order, sorry. So 2 slides, 3 slides. Okay. So we have this test called as polysomnography. Karakan was the first person to actually state that there could be this thing can be used in order to make a difference between organic and psychogenic erections. So earlier testosterone was found to be the main cause, but as we had certain studies, they told it was seen that children with low testosterone levels and in males where testosterone levels are undetected, that they also have sleep-related erections. So now it is not androgen dependent but androgen sensitive. There are 2 easy ways in order to sleep-related erections. One is a stamp ring test. You can get 4 to 5 postal stamps, make a ring of it, and tie it over your penis in the morning if it is broken. So we can say that there were sleep-related erections, but not a very effective method. And the last thing is we have Rigi scan. So they have 2 loops, one place at the base, one place at near the glands. The 2 loops monitor the penile circumference and radial and circumferential rigidity. If the NTPR test is normal, that suggests that the central and the peripheral nerves, especially the veno-occlusive mechanism, is working normal. If it is an abnormal test, then that doesn't give much detailed information about the etiology of the disease. And there are false negative tests also, like depression. The false negative tests are seen in depression, negative dream content, sleep disorders, and alcohol consumption. Thank you. Thank you for patience. And I think you all avoided this health of
Role of meditation.
Sir, not much role of medication. Meditation is there, sir. Yeah.
Thanks, Dr. Aatmik Jain, for a wonderful talk.